Thank you for the introduction, and thank you for the invitation. So as you might know, not all our memories are created equally. As William James, so a famous American psychologist, already noted in 1890, of some experiences no memory survives the instance of their passage. Others are recalled as long as life endures. How can we explain this? So in other words, some experiences, most experiences that we have, later on we create no memories of those. But other experiences, we have a very strong and lasting memory. So how can we explain that? That is exactly what I'm interested in. What is the difference between a memory that is being recalled and a memory that is forgotten? And if you think back to your own personal past, then these are especially emotionally arousing experiences that last. And that can be a very positive, a nice romantic vacation you will remember for the rest of your life. It can be a negative event. So both positive and negative emotionally arousing experiences will stay longer. And normally that's a highly adaptive mechanism that we are selective in determining what information will be stored and what information will not be stored. Because actually most of the information that we get to ourselves during a day is completely useless to store. I mean, just think about all the sensory information that enters your ears and your eyes. Most of it is not worth to store. But we need to make a selection to determine what needs to be stored and what will not to be stored. And it's mostly the emotionally experiences that are important experiences. Think about an animal. If it sees a predator, that's a very important thing to remember. Or when it finds a place where it can find food, that's a very important event to remember. But despite the fact that it's normally highly adaptive, highly emotionally arousing experiences or traumatic experiences can also lead to traumatic memories, post-traumatic stress disorder, and also other fear-related disorders like phobias and compulsive disorder. We know that during arousing conditions, you have the release of stress response systems. For example, here you see the sympathetic nervous system. So you get, that's a neural system that gets the activation of the heart and the blood pressure, and you get an increase in glucose, all necessary for an immediate response to the stress, the fight-flight response. You also get the release of epinephrine, so adrenaline from the adrenal medulla. This hormone is also important to increase heart rate, blood pressure, respiration, and glucose levels, so you can respond. But as we will see, this hormone also has an effect on the brain to facilitate the memory of the event. On the other hand, we also have the activation of the HPA axis, so ultimately leading to the release of glucocorticoid hormones from the adrenal cortex. So in humans that is cortisol, in animals, rodents, that is corticosterone. Also these hormones are doing important things in the more or less immediate response to a stress, although slightly delayed. Also there you get an increase in glucose levels and immune suppression, but also these glucocorticoid hormones feed back on the brain to have an effect on memory, as I will show you. So the outline of my talk is I want to start with some animal studies to give you the necessary mechanistic insight into the effects of glucocorticoid hormones on different aspects of memory. And we need that information in order to understand how we can use this knowledge to come up with new methods to treat patients where we actually have unwanted emotional arousing information. So that will be the second part of the talk. Okay. So I said I want to start with the basic studies, and actually the fact that stress hormones have an effect on memory is pretty old. This is actually the first study done in 1975 by Paul Gold, actually in the lab where I worked later in California. And what they did, so they placed a rat in this white compartment. It's called an inhibitory avoidance apparatus. Rats don't like white compartments, so they walk to the dark. But then you see there is a little sliding door that can be lifted, so the rat is confined in the dark compartment, and then it gets a 1 second mild electric shock to the paws. It's not painful, but let's say it's an unpleasant surprise, I would say. And then immediately after the training, you take them out, and then you inject, in this case, saline or epinephrine to the animals, and you see what is the effect 2 days later on the memory. And so 2 days later, you place them back in the white compartment, now with the door open, and you just say, okay, how long does it take for the animal to go to the dark? Again, the animals, they don't like the white compartment, so they actually want to go to the dark. But if they remember that something bad happened, it will take them longer to go there. And you see that in this case with the control injection, so it takes them about 60 seconds to go to the dark, so about 1 minute. If you inject them epinephrine immediately after the training, then 2 days later they have a much longer latency. So the epinephrine enhanced the memory, because the test is 2 days later, so there is no epinephrine there anymore. But if you first train them and then wait 10 minutes and then give the epinephrine, you see the effect of epinephrine is a little bit less effective. And the longer you wait, the smaller the effect is. So shortly after the learning, so there is a period where you can modulate the strength of the memory by giving a stress hormone. And that is because the memory is still in the process of being consolidated into a more permanent long-term memory, called the consolidation period. Outside that period, you cannot enhance the memory. Okay, so epinephrine can enhance memory, that's nice. But the problem is epinephrine does not enter the brain. So that's a problem. So that could mean two things. Either memory is not in the brain, or that epinephrine must find an indirect way to influence the brain. And I can tell you the latter is true. So there are now several studies showing that epinephrine can actually bind to receptors, beta receptors, in the periphery on the vagus nerve, and that these will activate nuclei in the brainstem, noradrenergic nuclei, that project norepinephrine to all over the brain. So actually, an epinephrine signal in the blood is translated into a norepinephrine signal in the brain. And for example, if you give a blocker of norepinephrine here, for example in the amygdala, you block the enhancing effect of epinephrine on memory. And we know that many different drugs, here I have two examples of GABA and opioids. These are two drugs that impair memory. They work by, in this case, decreasing norepinephrine in the amygdala and also in other brain regions. Because also if you give a beta blocker, you block the memory impairing effects of these drugs. On the other hand, there are also memory enhancing drugs, like for example the antagonists of these. Also these effects you block by giving a beta blocker. So the norepinephrine seems to be the central system where all these other systems act on. And we know that if we train a rat, so this is a microdelicis study, so you can directly measure norepinephrine levels in the brain, in the amygdala in this case, and in this case here, they were trained with this food shock, and these are 8 individual animals, and you see they all show an increase in norepinephrine levels. So emotional arousal by itself is inducing the release of norepinephrine in the amygdala, but also in other brain regions. And here you see if you directly inject norepinephrine in the amygdala, then you have a similar memory enhancing effect, dose dependent, relative to, for example, the epinephrine administration. But as I told you, after stressful event, you not only have the release of norepinephrine leading to activation of noradrenaline in the amygdala, but you also have the release of corticosteroids, so slightly later. But corticosteroids are lipid hormones, so they can directly enter the brain. And so slightly after the norepinephrine signal, you have an increase also in corticosteroids. But there is a temporal overlap. So one thing I was interested in is, do glucocorticoid effects on memory also interact with norepinephrine to enhance memory? So we investigated that in several studies. So actually the first one is more than 20 years ago, where we trained rats on the same task. And now we gave the synthetic glucocorticoid dexamethasone to these animals, and you see that also enhances memory, just like the epinephrine. But if you give a beta blocker in the basal amygdala, we completely block the memory-enhancing effect. And we use different type of beta blockers, beta 1 and beta 2 receptors. It doesn't matter. If you block the beta receptors in the amygdala, you block the enhancing effects of glucocorticoid hormones on memory. So glucocorticoids need an interaction with norepinephrine to have an effect on memory. And that will actually be important for the clinical part. So if this is the case, that glucocorticoids interact, that emotional arousal induces release of norepinephrine, and that glucocorticoids interact with norepinephrine, does that mean that glucocorticoids critically interact actually with emotional arousal? That is important, because so far we trained them here on an arousing task, where you have the endogenous release of norepinephrine. But what would happen if you would train them on a task that is not arousing? Would glucocorticoids still enhance memory? In rats, that's a bit difficult to investigate. In humans, it's very easy. You give them arousing pictures or non-arousing pictures and see what are the effects of these hormones. But in rats, actually, they don't do anything if you don't either reward them or punish them. But we use this task called an object recognition task. And in this task, you basically place them just in a box with two objects. And they can just explore these objects. And after a delay, you place them in the same box, but now with one of the objects replaced. So if the rat remembers that it has seen the light bulb, you see, a very boring task, it will actually spend more time exploring the new object. So this task by itself is nothing aversive, nothing appetitive, but still, you still need to put an animal in a novel environment, and that still induces some level of arousal. So we actually made use of that by creating two groups. So we had one group where we habituated the animal, so we placed them every day in that box, twice a day for 7 days. So the animal is completely used to the environment, and then gave it the training. And the other group, they were not habituated to the environment. So the training is exactly the same, but in one group the animals are aroused by the context. In the other condition, they are not aroused because they know the context. And then you see that if you give glucocorticoids in the condition where the animals were not habituated, so where they're aroused, so glucocorticoids enhance. So 0 means that they spend equal time exploring these two objects, so they have similar, no memory for the previous object. And the higher bar means a stronger memory. So glucocorticoids enhance memory in a arousing condition. If you do this exactly the same in animals that were habituated, you do not see the effect. So indeed, glucocorticoids need emotional arousal to have an effect on memory. Now there are actually quite some studies in humans where they show exactly the same. Glucocorticoids enhance memory for arousing information, but not for neutral information. This does, of course, not show that norepinephrine is the critical component of the arousal. And that's what we wanted to show. So in this case, so the hypothesis that glucocorticoids enhance memory because you have this arousal-induced norepinephrine. So to investigate that the norepinephrine is critical, we also gave the corticosteroid together with propranolol, so a beta blocker. And then you see that the memory-enhancing effect of glucocorticoids is completely gone. So indeed, glucocorticoids need this noradrenergic component of arousal. Here the hypothesis is so that glucocorticoids do not enhance memory because there is a lack of noradrenergic activation. So what would happen if you would give the glucocorticoids together with a low dose of a noradrenergic stimulant? Would it be sufficient then for glucocorticoids to enhance memory? That's what we investigate. So we gave here the glucocorticoids together with a low dose of yohimbine. And you see the yohimbine by itself does not enhance memory. The glucocorticoids by themselves do not enhance memory. But combined, you get the memory enhancing effect. So indeed, it's the noradrenergic component of arousal that critically interacts with glucocorticoids to enhance memory. We did a lot of studies on the actual mechanism of that interaction. And I don't have time to go into the studies, but the summary of that is shown here from a recent review paper, where glucocorticoids actually bind to a membrane receptor to induce a fast, non-genomic effect. So this is a different type of action than the classical steroid effects, where you have the gene transcription. And then it interacts directly with the norepinephrine signaling pathway, and the resultant is actually the release of endocannabinoids. And these endocannabinoids then shut off GABAergic transmission, and because of that you get a further increase of these noradrenergic terminals. So by giving the glucocorticoids, as a result, you actually get more norepinephrine, and also the norepinephrine signal is more sensitive. And the endocannabinoids are a critical step in between. Okay, so I showed you so far that glucocorticoids and norepinephrine of epinephrine interact with norepinephrine in the amygdala to enhance memory for arousing conditions. But the important thing is the amygdala is not the place where all these memories are stored. What we have shown is that the amygdala activation can actually modulate memory processes in other brain regions. For example, the amygdala can interact with hippocampus to modulate memory for episodic, declarative information. It can interact with the caudate nucleus to modulate memory for habit type of information, or with the neocortex for, again, other type of information. And well, here you see just a connectogram from a monkey brain, and here you see the amygdala, and you see the amygdala is indeed anatomically connected to many different brain regions. So anatomically, the amygdala is able to modulate memory processes in many different brain regions. And here you see one study where the rats were trained again on this inhibitor avoidance task, and immediately afterwards they were given a memory-enhancing dose of clenbuterol, so also a noradrenergic agonist in this amygdala. And in this amygdala they get control. And now 45 minutes later, here the hippocampus was taken out, and we looked at the density of a protein that is important for neuroplasticity. And so the question is, if you do something in the amygdala, can you alter neuroplasticity in the hippocampus? That would provide evidence that the amygdala can modulate memory processes in other brain regions. And that's exactly what we showed here. So if you in both cases have vehicles, so then the ratio of this ARC protein on this side and that side is 1. But if you inject clenbuterol on this side, then you have more ARC on the stimulated side. So indeed, by stimulating the amygdala, you create more plasticity in the hippocampus. And if you inactivate the amygdala by lidocaine, so local anesthetic, you actually reduce the amount of plasticity. We actually did a lot of different studies. We also showed that this ARC protein expression is necessary for the memory. So here we did the opposite. So in this case, we gave a glucocorticoid. This is a selective agonist for the glucocorticoid receptor into the hippocampus after this inhibitor avoidance task, and you see that also enhances memory. But if you block norepinephrine in the amygdala, you completely block the effect. So even a drug that is given directly into the place where you think the memory might be stored, if you block the norepinephrine in the amygdala, you completely block the memory effect. So the amygdala noradrenergic activity is absolutely necessary for modulating memory processes all over the brain. We have examples with about 30 different brain regions and 30 different drugs. I'm not going to talk about that. Yeah, so I showed you that both glucocorticoids and epinephrine via an increase on norepinephrine actually enhance the strength of memory. But the question is, do these hormones exactly do the same? Or also differences? And especially, we recently started to investigate that issue in relation to actually the accuracy or the specificity of the memory. Because human studies, they actually show that it's quite confusing, that literature. It's very old literature showing that emotionally arousing experiences are remembered in a strong way, but you remember more the gist of the information, but not the specific details. But there are also quite some studies that show that the emotionally arousing experience, you actually remember the details. And it's completely not understood what could be the difference between these two. So we did a couple of studies, and I just want to show you one. So this is this traditional inhibitory stase, where we place the rat in one box, they get a shock here, and later we place them back. And okay, we get longer latencies, but we don't know how specific that memory is. What would happen if you place them in a completely different box? Would they also show long latencies? Are they simply more afraid? So what we did here, we made a modified task, where we train them actually in two boxes with a very short delay. You see they are slightly contextually different. And in this box they did not get a shock. And 1 or 2 minutes later we place them in this box and they got a shock. And so the question is, do they remember that this is the bad box? So do they stay out of this box, but not out of that box on the retention test? And to make it a little bit more difficult, on the retention test we also gave them a box they had never seen before. Yeah? And so here you see that, and so we train them either with 1 or 2 minutes in between, and we gave them systemic injection of either yohimbine, so the noradrenergic stimulants, or the glucocorticoids. And if there is 1 minute in between, so actually so these two training episodes are very close together, then you see that the control animals, they actually don't really remember. They remember that they have seen these two boxes compared to the novel box because they have longer latencies. So they also remember that something bad happened. But you see the latencies are exactly the same. So control animals have a problem in dissociating or discriminating where they exactly got a shock. If you inject yohimbine, so you get a stronger memory, but you also see that they perfectly remember now where they got a shock. So the yohimbine made the memory stronger, but also more accurate. On the other hand, if you give the corticosteroid, they had a similar strong memory, but it's not accurate. And if we had 2 minutes in between, then you see that the control animals actually now have accurate memory because you made it a little bit easier for the animals to store it as two different episodes. And then again you see that both cort and yohimbine made a stronger memory. In this case, in the yohimbine, it remained accurate, but the corticosteroid actually it lost the accuracy. So you see that both noradrenergic stimulation and glucocorticoid stimulation both make the memory stronger, but they seem to have an opposite effect on the quality of memory. The yohimbine seems to make memory more detailed, more accurate, whereas the glucocorticoid actually induces a more generalized memory. And this is also very important in relation to the clinical implications, although it is quite new. Okay, I want to show you a little bit about some studies in healthy humans to show actually that the findings of the humans, who have been mostly done actually after the animal studies, are quite similar to the findings what I just described to you. First of all, if you present humans arousing information, you get activation of the amygdala, just like you get activation of the amygdala in the animals. Furthermore, if you show them arousing information, so you get the activation of the amygdala, and that activation of the amygdala actually correlates with the strength of the memory, in this case 3 weeks later. So in this case, this was a PET study where humans were presented with a series of arousing movie clips or neutral movie clips. And then you see that the amygdala activity correlates with how many films they record later, but only for arousing information and not for neutral information. So very similar to what I showed you before, that the amygdala is important for modulating arousing information, not for neutral information. Furthermore, if you give a beta blocker to humans, you actually reduce amygdala activity, but you also impair the memory enhancing effect for arousing information. And this is a study where they either gave also a beta blocker to humans, or they had patients who had damage to the amygdala. And they presented them with a story of 3 parts. First, a neutral part with neutral information, then the part with arousing, emotional information, and then the later part with neutral information. And you see that control subjects, they have a better memory for the emotional part of the story, but the subjects that were given propranolol or the patients with amygdala damage, they have no memory for the neutral information, so their general memory is not impaired, but the enhancement by emotional arousal on memory, that is selectively blocked. And this is also a study showing that the amygdala actually interacts with the hippocampus, in this case for declarative information. And of course, there is now a lot more coming out that the amygdala is part of a larger network. Okay. Actually, I want to show this part first. So I showed you so far that glucocorticoids, or that stress or arousal, so induced release of glucocorticoids, and that via an interaction with norepinephrine you can enhance the consolidation of information. But that's actually only half of the story, because we also know that glucocorticoids actually also in interaction with norepinephrine can impair the recall of information. So it depends on when the glucocorticoid levels are elevated. Are they elevated shortly after you learn something? They enhance information of new information. Are your glucocorticoid levels elevated just before you have to recall something? They actually cause an impairment. So I investigated that in quite some studies. And one of the studies we did was in a water maze. So in the water maze, you place a rat in a big tank with water, and they need to find a location, a platform, where they can escape on. They cannot see the platform. It's just submerged underwater, so they need to use spatial cues in the environment to try to find it. But after a couple of trials, they learn to find it, and then on the retention test the next day, they actually take away the platform and you kind of look at the swim trial. Do the animals, in this case, swim very close to where the platform used to be? That means that the animal remembered the task. And what we showed is that control animals, they spend much more time in the place where the platform used to be than in the opposite. So control animals, they remembered. But if we stress the animals, in this case 30 minutes before they have to perform the task, they were unable to do so. You see, they spent about equal time in these both quadrants. So they didn't remember anymore where the platform used to be. But 4 hours later, they remembered again. So this is a temporary effect. When they are stressed, at that time they had some problems recalling information, but if the stress is gone, they remember again. And here you see 2 minutes after the stress, the memory is still intact. So it is not the stress per se what is causing the memory, this must be some mediator of the stress. And you see that this actually corresponds with the plasma corticosteroid levels that actually also peak at this 30-minute time point. If we block the synthesis of corticosteroid, we block the stress-induced retrieval impairment. And in this study, we just directly gave glucocorticoids, corticosteroid, to the rats shortly before, so half an hour before they had to recall the information. And you see that administration of glucocorticoids is sufficient to block the retrieval. So glucocorticoid is the component of the stress that is impairing the recall. Also, these effects depend on norepinephrine, because here you see, if you give a beta blocker, then you completely block the impairing effects on 2 different measures by the glucocorticoids. And so we also did that in healthy humans. So in the first case, they had to learn 60 words. And then the next day they came back, and then we gave them either placebo or cortisone, oral administration, and 1 hour later they had to recall as many words they remembered. And then you see that in the placebo condition they remembered about 17, 18 words out of the 60. In the cortisone condition they remembered only about 11. So you got about a 30% reduction in the number of words they remembered by this single administration of cortisone. If we did the same study in the PET scanner, then we actually found that the cortisone condition reduced hippocampal activity during the recall. So that also fits with the animal studies actually, that the glucocorticoids might directly impair hippocampal function, leading to an impaired recall. We also did a study to try to find out if, because of this interaction with norepinephrine, glucocorticoids selectively modulate memory for rousing information and not for neutral information. So we gave them here either high arousal words like gun or terror, or low arousing words like pen, table. And then the next day they had to recall it, and you see if you give cortisone before, then we get a selective impairment in the recall of arousing words and not of neutral words. And that impairment is also blocked by giving propranolol. And the propranolol by itself did not have an impairing effect. So very similar to the enhancing effect of glucocorticoids on consolidation, there is this critical interaction with norepinephrine, and that's why it only modulates memory for rousing information. So to summarize the first part, so I showed you that glucocorticoid hormones can enhance the formation of emotional memories, of emotional information, and that is because of a rapid interaction with the nervous system. Second, glucocorticoids impair the recall of information. Also, these effects depend on this interaction with the nervous system. So we have these 2 opposite effects, but both are selective for arousing information. That is what you need to remember to go to the clinical part, where I want to go now. So we did, and I have to say the animal studies really I did in my own lab. The human studies I always did in collaboration with clinical partners in Germany and in Switzerland, but I was always involved in these studies. So as you might imagine, this is a traumatic experience. If you survive the accident, just imagine you're sitting here in the back seat and you survive it, then you probably have traumatic memories with all kinds of problems like intrusions, nightmares, etc. And so this is one of the examples of some of these unwanted traumatic memories. So the question is, can we use what we have learned from the animal studies about how these stress hormones modulate both the formation but also recall of these traumatic memories? Can we use that to, on one hand, understand what's going on in PTSD and in other fear-related disorders like phobias, but also to come up with possible new treatments based on that work? So in one collaboration we work with a group in Munich where they look at intensive care unit patients with different type of populations, and the advantage of this is that this is, first of all, a very clean population. I mean, if you have war veterans, there is a lot of comorbidities like depression and alcohol abuse or drug abuse, etc. These people are just having to go to the hospital sometimes by an emergency. It can be organ failure or like heart problems. And the second thing is, this is the condition basically where the trauma is there, and you see, first of all, you see it's a very traumatic place to suddenly wake up, and all these people are intubated, so They suddenly cannot breathe when they wake up, and that's a very traumatic experience. But you also see there are a lot of tubes where they give all kinds of different drugs to these patients. So you can see exactly what is the influence of all of these drugs on their memory later on. And of course, almost all of these patients get adrenergic drugs, epinephrine to increase heart rate, norepinephrine to increase blood pressure. They sometimes get glucocorticoids, especially by organ problems, to suppress immune system. They get opioids, all kinds of stuff they get. And so you can directly see what is the consequence of the drug that you give them on their traumatic memory later on. And interesting thing, I mean, a lot of these people have traumatic memories, almost all of them have traumatic memories. And about 30%, it depends on the type of the reason why they are in the intensive care unit, but in the more severe cases like organ failure or sepsis, about 30% of these people actually develop post-traumatic stress disorder. That's not really what you think of if you go to the hospital because you want to be treated for a heart problem, that you might end out with post-traumatic stress disorder, but that is the reality. And that results in a significant impairment in health-related quality of life. So these patients are simply not satisfied with their treatment. If they get a valve replacement, they also complain that the new valve doesn't work. So it is not only the psychological or the psychiatric problems that are there, but also the health, the actual physical health problems are still there. And of course, nowadays, it's more and more important that patients or clients are happy after they leave the hospital. So that's why the doctors are concerned in unhappy patients. And if you look at the type of traumatic memories that people have, and this was the questionnaire. So this was after acute lung failure. And then the question is, so this was 6 months after the discharge from the intensive care unit. And so when I think back at the time of my severe illness, I remember either having nightmares, anxiety, panic, pain, or respiratory distress. And you see that in this case, more than 60% of the patients remembered that it had nightmares. And about 40% of these other categories. So these were 4 predefined categories, otherwise you get all type of emotional memories that these people might remember. But you see, it's very often and very frequent, these emotional memories, so long after the event. And the second thing what is then measured is the PTSD score. So they basically have to rate if they have any of these 10 symptoms on a scale between 0 and 7, where 7 is the highest. And then, and that is what they have at the moment. So if they still, 6 months later, still have sleep disturbances or still have nightmares, etc. And then you see that you get ultimately in PTSD score, so where 70 is the maximum. And you actually see a correlation with the more traumatic memories these people can remember at that time, so the higher the PTSD score is that they have at that time. And so 35 here is the clinical setup. So if you have a lot of traumatic memories, there is a large chance that you are the one who will develop post-traumatic stress disorder. An interesting observation was here that this is in a group of cardiac surgery patients where they gave a subgroup, they gave hydrocortisone during the surgery, just a single administration, and then they looked at their traumatic memories 6 months later, and the group that received the hydrocortisone actually had more traumatic memories. So you could say this is a real-life situation of what I described in the animal studies, where you give glucocorticoids to an arousing situation, you enhance memory. Of course, this is not what you want clinically, to create more traumatic memories. But an important thing, as you probably all know, is that PTSD is often associated with lower glucocorticoid levels instead of higher glucocorticoid levels. And this is actually in the intensive care unit patients, and there it can be very pronounced. It's even known that in this critical illness that you can get an insufficiency of glucocorticoid levels. And those are also the ones that later develop PTSD. And here you also see that actually the more traumatic memories they later can recall, the lower the glucocorticoid levels they had at the time of the intensive care unit. So how can we explain that? So for that it's important to remember that after trauma you don't immediately develop PTSD. It takes, of course, a long time to develop post-traumatic stress. You have a traumatic memory, you re-experience that, you get flashbacks, you get release of stress hormones, and you strengthen that memory again. And so you have this positive feedback loop, and then over the course of many weeks or months, you might develop post-traumatic stress disorder. So in this loop of retrieving and consolidating again, so there are two components. So you have a consolidation component or reconsolidation component, but you also have a recall component. And so what we thought is that these lower glucocorticoid levels might actually make the subjects more sensitive to the recall. So you get a higher recall of especially arousing information, because that's only what is being influenced. And so if that is the case, then you would think that if you would treat people with higher doses of glucocorticoids for a more prolonged period, are you able to block the recall of this information? Yeah? So this is one study where this was also cardiac surgery patients, where the patients were treated with hydrocortisone or control for about 4 days, the entire time they were in the intensive care unit. And then the evaluation was 6 months later. And first of all, you see again that if they have more traumatic memory, so we divided them in subjects having no traumatic memories or subjects having more than one or multiple traumatic memories, and then you see that again that having multiple traumatic memories in the control situation is associated with more of higher PTSD score 6 months later. But you see that hydrocortisone treatment at the time of the intensive care unit so significantly reduced the PTSD score 6 months later. And there are now several studies from the same group, but also from other groups, showing that glucocorticoid treatment can actually prevent the development of post-traumatic stress disorder. It is, from this study, it's more difficult to determine what is exactly the mechanism. Is it because of this impairment in recall? Is it another mechanism? It might just cause a desensitization of the effect. We don't know if it could also have an effect on the consolidation. With chronic situation may be different than opposite. So we wanted to investigate it at some different ways. And so here you see the different memory aspects and the possible uses of glucocorticoids to influence that. So if you have an aversive event, a trauma, first of all, the memory needs to be consolidated to get a traumatic memory. So if you would like to manipulate that, you would think that you want to give a glucocorticoid antagonist to block the glucocorticoid response. The difficulty is mostly you are too late, because the consolidation process, I showed you in animals, it takes a few hours, and most patients, they go much later to seek psychiatric help, because certainly if it's an accident, they need to save their life, etc. So it's infeasible to use that approach. There are also no studies doing that. The second thing is what I told you, that you have this positive feedback loop where a first memory is retrieved, you get the expression of fear or of the trauma, and you get consolidated again. So you could try to give an antagonist to block the reconsolidation of that process. I think there are 1 or 2 studies that try that, but they are not successful. The other thing is, so you could give glucocorticoids to actually suppress the recall of this information. And the other thing is that normally you might get an extinction of this fear response to get an extinction memory. And that is a new memory that needs to be consolidated. So by giving glucocorticoids, you might also enhance the consolidation of the extinction memory. So for both, there are now quite some studies which seem to be successful. This was the first study that I was involved in. This was a Swiss study, very small group of subjects. This is just one subject, what I want to show you. This was at PhD for about 4.5 years. So it was constant PhD. It got just more or less some anti-anxiety drugs and some sleep medication, but the PhD scores remained very stable over this period. And the subject was asked to write down in a diary the intensity of reliving the event or sort of nightmare, so really a recall measure of it. And then you see in the first month the subject had a placebo, so on this arbitrary scale it had about, let's say, 2 events a day. But under the next month it got a very low dose of cortisol, and you see that the number of intrusions was significantly reduced. And on the last month there was no medication anymore, and okay, it went up a little bit, but it was still lower. So this must be a retrieval effect. It might be that this is actually some extinction effect, but that is more difficult to say. Okay, so the other thing is, okay, does it also work in other fear-related disorders like phobias? Because also here you see 2 examples of 2 different phobias, social phobia and spider phobia. And in both of these situations there are very strong memory components. Whenever you are in a situation like this, you have to think back about previous encounters and how embarrassing that was, etc. So these emotional memories from your phobia, they will return. And in one study, this was done in a group of social phobia patients, and we told them here that they had to give a talk in front of an audience. And you see immediately the fear response went up in these subjects, because that's very cruel to do, to tell social phobia patients that they have to give a talk in public. But you see, if we gave them cortisone before that, then there was a significant reduction in that. So the hydrocortisone buffered the fear response. In this case, of course, we measured fear. We did not directly measure memory. And what we further found was in the control subject, we actually found a negative correlation with the endogenous increase in cortisol and the fear response. So we see also here that the higher the endogenous cortisol response is in response to us telling them that they had to give a talk, and the fear response that they had. So you see that also endogenously glucocorticoids seem to have a fear buffering system. In the spider phobia patients, actually they saw this photo of a spider. And this was 6 sessions, and they had to rate how afraid they were. And so this was in 2-week period, and you see that in control subjects treated with placebo, so they actually get a very similar rating over these 2 periods, so you did not get any extinction. In this group, the first day there was no drug treatment, so it was control, basal measurement, and you see that a similar rating. And the next time, 1 hour before the session, they got hydrocortisone treatment or cortisol treatment, and you see you get a reduction in the fear ratings. So this effect can only be because of a recall effect, impairment, but you see that the effect actually gets larger over time. So that might also suggest it's an extinction effect. And the last day here, there was no drug treatment anymore. There was 2 days after the last drug treatment effect, and you see the effect is still there. So that must be because of an extinction effect. So the possible treatment of a summary, this is basically a similar figure as what I showed before, but now an older version of it. So you have in the first of memory, you get a retrieval. So glucocorticoids can block or impair that retrieval, then you experience that. And of course, if you see an event, but you don't experience it as arousing, that by itself already creates an extinction memory, because now you can see something without having the negative experiences what you normally have. And so at the same time, glucocorticoids can also facilitate the consolidation of that. So there are now a few studies that looked at the effect of cortisol directly on extinction. So one of them is with fear of heights. So this person is not somebody with fear of heights. In this case, that's a virtual reality experiment where subjects with fear of heights basically get in a virtual reality environment, and the ultimate goal is that they have to walk here from this building to that building. That's very scary for them. And so here you see the fear ratings, and so you see that the therapy by itself is successful, so they get 3 of these sessions, so you see that the fear ratings really went down. But if the subjects were treated with cortisol before the session, so you see the effect is even larger. And 30 days later, the effects still exist. And I think there also now a follow-up probably 3 months later, and it's still existing. So glucocorticoids can really be used to facilitate the consolidation of the extinction memory. There are also now some studies in PTSD patients where it also seems to work. And as you probably know or should know, glucocorticoid levels are not constant during the day, but actually in humans we have a morning peak and then the levels go down during the day. So if glucocorticoids are so important in regulating the extinction memory, and glucocorticoid levels are higher in the morning than in the afternoon, would it have consequences for the effectiveness of exposure therapy in the morning versus the afternoon? So this is a study done by a German group where they either had, so these were also spider phobia patients, if I'm correct, and so they either had exposure therapy in the morning or in the afternoon. And you see that the exposure therapy worked actually better in the morning than in the afternoon. Also at 3-month follow-up, the effect was still significantly larger. So this really supports the idea that glucocorticoid levels, and it actually correlates with glucocorticoid levels. So this supports the idea that the glucocorticoid levels are very important in facilitating the effect of extinction therapy. So there are actually quite some studies now on different aspects with glucocorticoid treatment, either for the prevention of PTSD, what I indicated, or the treatment of social phobia, spider phobia, or fear of heights, on both retrieval and extinction. And in many cases, the effects are successful. I have to say many of these studies are very small scale studies. What is really missing are some larger multi-center studies to test the efficacy. Okay, the last thing I want to indicate is actually some genetic and epigenetic modifications of that, because we have different polymorphisms in the glucocorticoid receptor. So one of the polymorphism is the BCL gene, that is a single nucleotide chain, so SNP, where a CC is altered into a GG. And so you see that in about 20% of the people, and it was already known that in healthy subjects, the carriers of this GG have a stronger or better memory selectively, again, for emotion arousing information, not for nutrient information. So this was also a study done after heart surgery, where we looked at the number of traumatic memories, but also PTSD scores 6 months after discharge for intensive care unit. And selectively, those subjects actually who showed this particular SNP but it's associated with a more sensitive glucocorticoid receptor and also lower glucocorticoid levels. They show the increase in traumatic memories. So this might be perhaps a way in the future where you might be able to pre-screen subjects to see who might particularly benefit from glucocorticoid treatment, because these did not get the glucocorticoid treatment. But if these are the ones who show lower glucocorticoid levels because of the heightened sensitivity, these might be the patients you want to treat beforehand. And these are probably also patients that on extinction might fail. So it might be that also in the future on extinction therapy, exposure therapy, if they might have this particular polymorphism, that these might be the patients that might particularly benefit from glucocorticoid treatment also to facilitate extinction. Another study I was involved in was also epigenetic modification of the glucocorticoid receptor. This was done in a population of survivors of the Rwandan genocide, living still there in camps. And as you probably know, DNA methylation of a promoter of a gene can suppress the gene expression. So more methylation, the lower the gene expression in more or less. And what was found here, that there were, within the glucocorticoid receptor, there were 8 of these areas found where they had methylation, so CpG islands. And there was one area that showed a significant correlation specifically with intrusions, so the memory component of PTSD. So it had no correlation was found with avoidance or alertness, but so again selectively with the memory component. So that also here makes the link between glucocorticoids and memory, and not with the other symptoms of PTSD particularly strong. And also here you see that the methylation of the GR actually correlated, the methylation of the GR actually correlated directly with the expression of the GR. So this is a functional change in the methylation. So to summarize and to conclude, so I showed you that glucocorticoids, so on the one hand, when it happens with new information via interaction with these arousal mechanisms, so can enhance consolidation of memory, but the same mechanism when it's elevated at a time when you have to recall information, so you can block the recall of information. So I think that this fundamental knowledge is very important in also knowing how to optimally use a drug treatment in PTSD, because you see that you really need a timed administration. You don't need to give a glucocorticoid, let's say, all the time. You need to give it right at the time where you need it. And if you would, for example, have an extinction session, you really want to boost that by giving glucocorticoids. But actually, if you would create a shorter session where you get more reconsolidation, you actually don't want to do that. You actually want to do the opposite. So the fundamental knowledge is essential, I think, in developing an effective therapy. And so to summarize, I showed you that acute glucocorticoid administration can enhance the formation of emotional information, of memory of emotional information, and it is because of interaction with the northern system, and the amygdala can interact with multiple brain regions. So the amygdala is very important in regulating the memory processes, but the whole brain is ultimately involved. And on the other hand, so glucocorticoids impair the recall of information. Also, these effects depend on this interaction with the northern system. And so the combination of these effects, on the one hand, so enhancing consolidation, impairing the recall, I don't think there's actually any other drug that is currently being tested in PTSD that have both these effects, and it might be that this combination effect makes it extremely effective. And the other thing is that it's selective for arousing information. Nutrient information is not affected, the IQ of the people is not affected, and most, of these, many of the other memory-enhancing drugs that are being tested, they might also affect your other memory that you want to spare. And there are many people I want to thank. So this is my team in Nijmegen. For the clinical studies, I really have to thank Gustav Schelling from intensive care unit patients, and Dominique for the phobia patients, and also the methylation study at the end. And I want to thank you for your attention. Thank you.